Welcome to Impact by DIFFA Dallas, the official podcast of the Dallas chapter of the Design Industries Foundation Fighting AIDS. We'll share valuable info about the fight against HIV and AIDS, what our organization is doing to assist those in our community, and most importantly, how you can help us make a real impact.
Welcome back to Impact. My name is Tim Gariffa. Today I'm happy to talk about the journey of the cause of HIV and AIDS. Today we have some fantastic special guests with us, Dr. Stephen Pounders and Dr. David Brehm. I'm going to let them take a second and introduce themselves. Stephen?
Hi there. I'm Stephen Pounders. I'm in private practice, internal medicine in Dallas.
Great.
And I'm Dr. David Brehm. I have a practice here in family practice in Dallas.
Awesome. Thank you guys for being here today.
Thank you.
Today, we want to talk about the journey that we've been on from an HIV and AIDS perspective. Dallas has been, present in the community. A lot of history has been made here. So that's what I want to, take our conversation through is what did we see in the 80s and 90s, kind of what happened during that time, and then get to where we are today. Mm-hmm. I think there's a lot of opportunity for people to understand where we've come from, right? It helps us understand what the need is today. And then, I want us to talk a little bit about what does it look like today, and maybe what does it look like tomorrow?
Sure.
Okay. So let's kind of talk through that, right? We've had a transformation. HIV used to be an epidemic. It used to be a death sentence. And I know, Dr. Pounders, you were involved in that in the beginning. So Why don't you kind of take us through, what was it like in the 80s? What did it look like back then?
Well, I could start with, I finished my residency in 1988, and I first started practice at the AIDS clinic at Parkland. And that's run by UT Southwestern. So I was there for a year, and believe me, I was part of kind of a solution. The clinic and the hospital and the UT system was sued by the patients. It was sued by some AIDS activists. We can name names if we need to, but that was a big deal at the time. And to make a big solution, they had to start giving out AZT to patients, and they had to hire more doctors. And so I was really fortunate to be in the middle of all that new stuff, and we started some research. And we gave a whole population of the Dallas indigents a new drug. AZT at the time was the only thing we had. It didn't work very well, but it did help some people live a little bit longer. So it was quite a active time. We got a lot of research out of it, and I had a lot of notoriety out of it, and it was a great time to help people. But it wasn't until 1995 that we had drugs that really worked. So we had people dying, and anyone who developed this syndrome of AIDS, HIV infection so bad that their T cells were impacted, they had either infections or cancers, they were very sick. Most of them had 6 months to live on average. So it was definitely a death sentence for people.
Yeah. So, let's talk about AZT was the first real drug that came out in the U.S., right, for HIV and AIDS. And it wasn't that effective, right? And so I know there's a lot of people that were kind of taking to their own means, going outside the U.S. to, seek other treatment and bring that back. There's a big movie that came out, Dallas Buyers Club, about that. Tell us a little bit about that and your link and what did that look like here?
So the movie is about Ron Woodruff. He's the protagonist, the main character. And, he had a doctor, of course, in the movie, and that was played by Jennifer Garner. And that's really based on my role. I was kind of Jennifer Garner in the movie. So
you changed.
Yeah, I kind of changed. Or they changed me. The screenwriters changed me. Right. But that's what they do in Hollywood, is make things fun or interesting or attractive or to make money. And it certainly did. It was a very successful movie, and it got a lot of people to understand about what was going on, because a lot of it was very true. So Ron was my patient, and he decided that he wanted to help patients get drugs that work. There's got to be something in the world. He would buy, borrow, beg, steal, smuggle, get drugs from anywhere in any country that he thought might help people. And at least he gave people hope. So when people brought these drugs back, here some of them are IV drugs, in other words, intravenous, they have to be injected. Some of them are pills. How do you do that? Somebody's got to start your IV. So the patients would come to me, and I would start their IV and give them instructions. And we didn't know if this stuff worked. I don't think we killed anybody, but did we help anybody? We at least gave them hope. So I know that the drugs helped in that regards. And it's really fascinating that the Dallas Buyers Club was like a block from where my office was on Swiss Avenue. And then 2 blocks down was the bathhouse where a lot of people maybe had caught the HIV infection itself. So it all happened right there in an interesting area.
It's interesting. There's a lot of history here.
Yes.
A lot of history here. And, times have changed. Back then, HIV and AIDS was in the news. People were dying every day from it, right? Now, it's different, right?
Yes.
Care is different. Treatment's different. And it's not in the news, it seems like, quite as much.
It's true.
So talk to us a little bit about, what does care look like now, right? Instead, it used to be a cocktail. People took, several times a day, maybe?
Yes.
And, now medication's so advanced that, it's not that anymore. It's once a day. It's maybe a couple pills a day, depending on what you're on.
Right.
So talk to us about what does care look like now?
So
It's completely different as I understand it. It's funny how you talked about that happening in the late 80s. I didn't become a doctor until I was in the late 90s, and I didn't start medical school until I was 93. I had no idea that all that was going on, which it brings up another entirely different point. This whole world was going on, and the rest of the world around it, so close to it, blocks away, we're totally unaware of it. And I'm hoping that, and I know that it has changed since, but I'm hoping it continues to change and becomes more and more prominent in everyone's lives, not just the LGBTQ community. But as far as advancements, now we have medications that can prevent the transmission and medications that in people who are HIV positive can get them to undetectable levels, which also then prevents transmission. So to me, it's become a matter of making those medications available to the communities and then educating the communities as well as the healthcare providers that also need just as much education to know that we need to educate the people who need it, the people at risk.
Yeah. Dallas has one of the highest infection rates in the country. One of the highest, right? The highest in Texas,
yes, unfortunately.
It's ridiculous.
It's horrible, especially to your point. There's medication now that not only if you are HIV negative can prevent you from getting the disease. If you have HIV, you can get to a point of undetectable, which I think the new branding is undetectable equals untransmittable. Is
yes.
that what
you
they're
equals
saying?
you.
You
Yes.
equals you, right? Which is fantastic.
It's great.
It's fantastic. In March, the CDC put out a report that said 80% of new infections in the U.S. are a result of people that are undiagnosed, right? So people that probably haven't been tested, that didn't know they were HIV positive. How do we fix that, right? There's this stigma, but how do we fix that?
At first, there was a big stigma back in the 80s. Don't get tested. In fact, all organizations said, don't go get tested. All it is a life sentence. There's nothing you can do to treat it. Yeah. That is so 100 degrees opposite now. I mean, people can take medication, get undetectable, have a normal immune system, and live a full, long, healthy life if they get into treatment.
Yeah.
So we have to get past that stigma. Yes, it's very difficult for some who have heard the message to not go get tested. But, a lot of young people feel invincible. They don't think they're going to get any disease, and much less a sexually transmitted disease. And that's exactly what HIV usually is, a sexually transmitted disease. Can be transmitted, of course, through any blood or body fluid. So sexual activity, IV drug use. It's not from blood transfusions anymore.
Right.
It hasn't been for many, many years through pregnancy transmitted to a baby. As long as a woman gets into care, we can prevent pregnant women from transmitting the virus to their children, too.
But a patient who has been diagnosed with any sexually transmitted disease, it's proven that they right there are at much higher risk for the transmission of HIV. So when they come into our offices and we've diagnosed them with any of the sexually transmitted diseases, alarms should be going off. We should have that discussion with them and say, look, you are at risk for HIV transmission. And as I have had happen, unfortunately, several times, I will newly diagnose someone with HIV, and they had been thinking about it for months and months and months of starting PrEP, the medication to prevent it, and they just waited too long, and now it was too late. I said, well, then go out and tell those stories. So get people not afraid, but warn them that they can start PrEP and not be transmitted.
Yeah. I think one thing it's important for people to know is, 80s and 90s, this was seen as the gay disease, right?
Yes.
And, although it is a high-risk population, we're seeing disproportionately affected African American women, minority women in general. This is not a discriminatory disease, right? And so, with that, let's talk about, access, right? You talk about newly diagnosed people. Medication is expensive, right? And especially some of the new HIV medication that, it's a once a day pill that if you don't have insurance, it's very expensive.
Yeah, about $2,000 to $3,000 a month.
It's just, out of most people's price range.
Oh, yes.
Right?
Oh, yes.
So how do people deal with that, right? When you have patients come in, how can they get the medication if, one, they can't afford it? Maybe they can afford a $200 premium a month if that's what their insurance, copay is.
Well, that copay is actually covered many ways. One, all of the manufacturers of the medications for HIV will cover people's copays. They will cover, one of them I know in particular covers up to $10,500 per year.
Oh, wow.
Covers all the copays, usually covers people's deductibles even. So there are ways to get these things covered. And almost all patients get their HIV medications for free. Okay. In other words, nothing out of pocket. At least they don't have to pay extra for it. Either their insurance pays for it, or they can go to many of the public facilities. There's a lot of grants through the AHF, which is the AIDS Healthcare Foundation. There are grants through Parkland. There are other supports available through many of the organizations. Right. And these are the reasons we need to support them so much, because they make these drugs available for patients to prevent and to treat HIV infection. Yeah.
And I know, DIFFA provides grants to several AIDS service organizations that provide medication and treatment and testing, right, specifically for this purpose.
Yes.
And then, of course, there's the big Ryan White funds. So I know some people can qualify based upon what is their income level. So there's absolutely opportunity for access, right? Yes. And, that's something that DIFFA and other organizations can help those people that need it. Right. So let's talk about, are there any myths that we should dispel, right? People that maybe don't know a lot about HIV and AIDS, don't know a lot about, medication. People talk about, if I take PrEP, it's more likely I'll have risky behavior. What are some, myths that we should dispel around these types of things?
I've even seen physicians address that by saying, I'm not going to talk to my patients about their sexual activity. Really? If I don't ask about it, it's not really happening. But it is. They're all having sex. It's a very normal human function.
That's an example of the education that we need for the healthcare providers, so they know that that's nonsense. And again, it's going to be vital to educate the providers.
Yes.
Okay. So if people are not getting maybe what they need from their doctor, what advice can we give to people that want more information or maybe to see another provider?
Maybe find a good provider. That's right. Maybe find a different one that you can talk to. Yeah. I think it's really important for any patient to choose a provider they feel comfortable talking to, that they can tell all of their personal information. HIV, it doesn't really discriminate. It's a matter of just behavior. If somebody shoots or has shot IV drugs, if they have sexual activity with any more than one person in their life, and maybe that person they have sex with has had sex with somebody else in their life, very likely, they should be tested. Many strategies have come forth to try to eradicate new HIV infections, and one of them is test everybody. Yeah. And when you go into an emergency room, you are getting tested for HIV unless you sign that I don't want to be tested. The default is you're here, you're coming to our facility to be treated, you need to be tested for HIV. Now, you can opt out. You have the right to say, no, I don't want to be tested, but it's offered. And it's recommended for every American in the United States to be tested at least once. Yeah. And after that, it depends on their behavior. How much behavior they have and what kind of behavior might determine how frequently they need to be tested.
So we've been on this journey, right, as far as the cause goes, from beginning with AZT and people dying and really not taking long from the time they're diagnosed to the time they are no longer here.
Yes.
Right, to where we are now, where people can live a full life, right, and be HIV positive, be undetectable with the right level of medication. One of the things that I found interesting is for the longest time, I feel like PrEP wasn't really marketed or advertised in Texas, and now I'm here. I even heard it on 106.1, on the way here this morning, right? There was an advertisement for PrEP. And that's fantastic, right?
Yes.
So with what you guys are doing, what do you see as the current need, right, in North Texas? What do we need to get out there around education? What is the need of the community in order to really start making an impact and making Dallas not one of the highest new infection rates in the country?
I think, again, it's just constantly being out there, making a presence known that this can stop. We can get the transmission rate significantly lower, if not ultimately to zero. And it's a matter of just hitting that message over and over and over and over again. I mean, I'm a physician, and I didn't know what PrEP was until about maybe 6 or 7 years ago, or a little bit longer than that. And I read about it on social media.
Right.
And so that was an example of two physicians making various webcasts or podcasts and just talking about it in a comical way, in a light way, and it grabbed people's attention. And I think that's things like that. That's just one way of getting the message out. But we've got to hit the message all the time.
Right.
At least in Uptown and Oak Lawn area, I see billboards, there are street signs, get tested, get PrEP, a lot of information, a lot of ads are going on TV, social media. I think the message is out there. We need to get it to everybody.
Right.
It has to be standard of care.
Right. What do you say to people that are too scared to get tested, right? And I had that problem in the beginning, right?
Sure.
I'm a little anxious. Like I didn't feel like I was at risk, but it's still nerve-wracking, right?
Yes.
What do you say to people that are, contemplating not getting tested just because they're scared?
Well, being scared or not scared, getting support or not support doesn't get rid of the HIV. It's either there or it's not.
Yeah.
And we have to give people, this is like one more reason, one more little card in your healthcare book that needs to be checked.
Sure.
You don't want to have heart disease, so you need an EKG, you need your cholesterol checked, you need to eat healthy, you need to exercise, and if part of your behavior is sexual activity, then you need an HIV test.
Yeah.
And I think it's become pretty standard for people to get STD testing, to test for gonorrhea, chlamydia, mycoplasma, and syphilis. But HIV is one of those too, and they all need to be tested for. Yes, the HIV may not yet be curable, but it is so treatable that it's nothing to be afraid of. I would be afraid of not being treated and dying from it.
Sure.
And if you wait too long, it destroys your T cells and your immune system, and you get more than just the HIV infection. You can get what we call opportunistic infections, cancers, and those are the things that really have shortened people's lives in a hurry, in a short time.
Yeah. You mentioned, it's not curable yet. We're seeing advances in medicine every day.
Yes.
At the last House of DIFFA, we talked about some of the, progress that they've made in treatment and potentially curing some patients. There's a lot of exciting things that are coming in clinical trials, right? We've talked about AZT. We talked about now we got to a point of 1 pill a day. What do you guys think is coming? What's next? Gone to 1 pill a day. What's the next step from here?
Well, we have some incredible genetic tests that are able to go in, cut out DNA out of the cells. There's an animal model where they're treating hepatitis B, which is also a long-term chronic infection for many people who get it, unfortunately. But it is a treatable infection, so you don't hear a lot about hepatitis B killing people. Yeah. But in an animal model, they are able to go in and cut out that DNA, that dormant virus. And this HIV infection is also a dormant virus that can sit in the bone marrow, in the nerves, in organs. And that's the reason we've had trouble curing it, trying to get all of the DNA out of the body. Okay. There are several things, techniques are called CRISPR, CRISPR, and zinc fingers. And these are the methods they've gone in and able to cut out this bad DNA out of the body. And it's really exciting because we've got something that is able to do that.
Yeah. It does sound exciting.
Yes.
Right? And I think we are getting to a point where eventually HIV is not going to be, a topic that we'll have to address. I think we're going to get, eventually, that's the goal, right? To get to a point where we'll have a cure and it will no longer be around. Any final words that you guys want to share with the audience around, HIV, what people should know? Any words of wisdom?
I just want to say, I think you lived it from the very beginning. And so you've seen the drastic change and improvement from where we've come from the beginning to where we are now. And you had probably no idea we'd ever get to this point. And so that gives me hope. We've gotten to this point so far. When will we get to the next point? And that I am hopeful that there will be an immunization or treatment that's curable.
Yes.
But we just have to stay on this right now. And the younger generation that has not witnessed directly what you witnessed doesn't have those pictures in their minds, and they may not minimalize this, but they may lessen it a bit. But we can't let them do that. They've got to know how important it is to be tested, to be treated, to not be transmitted. That's what I have to say.
Yeah, we have to change that to the norm. The normal is, and I think it's getting there, but it's got to be, the normal is if you are young and you have multiple partners, that you get tested and you get onto treatment to prevent it. Yeah. And I think it's coming that way.
I think so too. I think we have the opportunity in Dallas to make an impact, and that's what this show is about. That's what DIFFA is about. I know both of you guys have played a role in DIFFA and Style Council and getting the word out in that way. So thank you guys for your activism and support of DIFFA in that way. Thank you guys for being part of the show today.
Thank you.
I've enjoyed the dialogue.
Great.
And for those of you guys that are watching, if you want to find out more information, you can go to our website, difffadallas.org, and tune in for our next show of Impact. Thanks so much for joining us.